I would be sharing few things about frozen embryo transfer, the preparation, how it is done. And then I'm hoping for a great discussion. All of us, I mean, our esteemed chairpersons who are there, all of them are big practitioners in the field of IVF. So let's hope we are going to get many inputs from them as well. So the topic which Dr. Sharda Jain ma'am has given me is the different ways to prepare frozen embryo transfer cycle. So as we all know that healthy seed, which is actually our embryos, is not enough to get a healthy sapling. Similarly, a healthy embryo needs a receptive endometrium for successful implantation. It is equally or maybe even more important. So implantation, when we talk about, it's not that, the embryo goes there and just sticks there. If we go at electron microscopy level, and if we, try to learn the endocrinology behind this, implantation is actually governed by array of endocrine, paracrine, autocrine modulators of both maternal and embryonic origin. I mean, there is a crosstalk between the embryo and the endometrium, and it's not that simple when it comes to implantation. So prior to implantation, day 5, day 6 embryo, the hatching happens. And after that, there are certain stages. So when we do embryo transfer, I always tell my patients that it's not that I have put in the embryo, it is going to go and stick there today only. There are different stages which it is going to go through. So there will be apposition, adhesion, and then finally the invasion of the blastocyst happens, and then implantation, if embryos are genetically good and if everything is fine, then implantation is going to happen. So implantation failure can occur if there is impairment of embryo developmental potential, if there is impairment of uterine receptivity, or this crosstalk or the embryo uterine dialogue is not correct. If your endometrium is out of phase for the kind of embryo you have put in, so then also implantation failures can happen. So there are different protocols which have been described in literature for endometrial preparation. Fresh embryo transfer is not the topic for today, but just a slide about it. We typically, on the day of egg pickup, start estradiol valerate 4 milligram daily. I usually give. Few people believe that it is not needed in fresh embryo transfer. Then progesterone, we usually start on the day of egg pickup if I'm anticipating an embryo transfer in the same cycle, which can be vaginal gel 90 milligram or suppositories or aqueous injectable micronized progesterone or the conventional one, or you can use dydrogesterone also. And usually I give 4 days of progesterone for day 3 or cleavage stage embryo and 6 days of progesterone for the blastocyst stage. Now coming to the topic for today, 3 main protocols which can be used in frozen embryo transfer cycle, and we will be discussing who favors natural, who favors HRT in their practice, and the stimulated cycle, and what are the advantages and disadvantages. So natural cycle, as the word signifies, it is absolutely natural, involving the monitoring and then looking for a spontaneous ovulation or spontaneous LH rise, and then doing the embryo transfer. That is natural cycle. HRT cycle, as the name signifies, it is hormone replacement therapy cycle with estrogen used for endometrial preparation, or sometimes some people give pre-treatment with GnRH agonist, which is typically given on day 20, 21 of the previous cycle prior to estrogen administration. That is HRT cycle. And then there is stimulated cycle, which can be in form of CC or letrozole stimulation, or sometimes mild gonadotropin stimulation is given for follicular growth. And then the embryo transfer is done. So now let's look at them one by one in little detail. So in natural cycle protocol, what happens is I will be doing a day 2 scan to rule out that there is no ovarian cyst or there is no other contraindication to go ahead. And usually, FSH on day 2, if it is more than 15, then we should not be going ahead in that particular cycle. Then after this, because it is an absolutely natural cycle, I won't be needing too many scans. I will call my patient on day 8 or day 10 for follow-up scan, and then leading follicle reaches around 17, 18 mm. If I give a trigger, then it is called modified natural. So usually in natural cycle, which is completely natural, either an LH can be tested. If LH is more than 20, you just follow the follicle ovulation is about to happen. So just look for that. Or if you are giving HCG and controlling the cycle, then it is called modified natural cycle. Then typically blastocyst transfer can be done LH surge post, 6 days after LH surge, or if you've documented ovulation, then after 5 days of ovulation, documented ovulation, blastocyst transfer can be done. Then comes the HRT protocol. So how HRT protocol is done? So daily dose of estradiol valerate typically started at doses of 4 to 6 milligram per day. My preferred dose is at least 6 milligram per day, starting day 3 and monitoring after a week to 10 days. Then we can keep on increasing the dose only if needed, because many people, they make a good endometrium even on 4 to 6 milligram of estradiol valerate. Then usually we don't go beyond 12 milligram per day. And once the endometrium is more than 7, for me, this is what literature says, but for me, I always keep my cutoff as around 8 mm and more. Start the progesterone after checking serum progesterone. If it is less than 1.2 nanograms per ml, then you can start the progesterone. And 600 milligram of micronized progesterone you can give. You can give injectable or can give 90 milligram of vaginal micronized gel. I prefer either injectable or do first on 10 milligram 3 minutes daily. Then 4 to 6 days of progesterone, depending on the stage of embryo to be implanted, you can go ahead for frozen embryo transfer. Now coming to stimulated cycle. So whenever we say stimulated cycle for frozen embryo transfer, then usually it means mild stimulation, because my aim is not to make too many follicles here. So I usually prefer letrozole cycles here whenever I am giving a mild stimulation, or sometimes low dose of gonadotropins also help. Then HCG is administered when leading follicle is around 17 to 18 mm. And then after HCG, after 5 days, if you are going for day 3, but nowadays nobody is going for day 3. So HCG plus 7 for day 5 blastocyst. So mild stimulation takes care of subtle defects in folliculogenesis. That is an extra advantage, leading to more favorable endocrine environment and improved endometrial receptivity. So this is as per this beautiful article in Frontiers in Endocrinology, that they say that stimulated cycle is a shade better than natural cycle. Now this table is very important. Let's spend around 2-3 minutes on this table, understanding the different types of preparation which we just talked about. And if you want to look at this, the article from which I have taken this is Endocrinology Review article, August 2023, and this is the article. So endometrial preparation in true natural cycle. What we have done is day 2-3 ultrasound to exclude any ovarian cyst or corpus luteum. Then day 2, consider cancellation if FSH is more than 15. Then it is natural cycle. So I'm calling the patient day 8. Monitor follicular growth daily or every other day until there are features of ovulation. Then how about the timing of embryo transfer? Confirmation of ovulation by ultrasound or by LH surge. And you can typically go for blastocyst transfer at LH surge plus 6 or ovulation day plus 5. Now coming to whether luteal support in true natural cycles is needed or not. So the literature says might have some benefit but needs more studies. Advantages of natural cycle are it is more physiological, cost effective, and there is a reduced treatment burden. But I think most of the people are not using absolutely natural cycle and are going either for mild ovarian stimulation or are going for a typical HRT cycle. Then, as I said, what is the difference between true natural cycle and modified natural cycle? So in modified natural cycle, what you have done is you have controlled the ovulation by giving HCG. So HCG trigger plus day 7. So I feel when you are controlling the ovulation, there is a better physician control over the cycles. So modified natural cycle also is a good option. Then luteal support might not have any benefit because we have corpus luteum here in both true natural cycle and modified natural cycle, which is naturally going to support the pregnancy. What is the advantage of modified natural cycle? It is more flexible, requires less ultrasonography and endocrine monitoring. Then let's look at what is mild ovarian stimulation cycle, how it is done. So day 2, I have given either CC or letrozole or gonadotropin. But CC usually should not be preferred because it has got anti-estrogenic effects on the endometrium, and we all of us know that sometimes we keep on struggling with the endometriums in our IUI cycles also with CC. So preferably letrozole and gonadotropins are preferred. Monitor follicular growth daily or every other day until dominant follicle is 17 to 18 and your endometrium is more than 7.5. And then you trigger the ovulation by HCG. HCG trigger day +7 is the time for blastocyst transfer. Or if you are practicing day 3, then HCG trigger day +5. Now, in modified ovarian stimulation, there may be some benefits of luteal support, but again, because there is not, if I'm giving, gonadotropin stimulation, then definitely yes, luteal support. But otherwise, in letrozole cycle, they say that you may avoid giving luteal support also. What we are doing, what everybody else is practicing, we will come to that, but this is what literature is saying. Then advantages, more favorable endocrine environment is there, and improved endometrial receptivity if you are using mild ovarian stimulation and then preparing your lining. Then coming to the HRT cycle. So in HRT cycle, estradiol step up, start with 4 to 6 milligrams per day. And I typically practice calling the patient around 7 to 10 days later. And if it is less than 6 then I usually step up, and you can go till 12 milligrams per day. Ultrasound monitoring for lining is typically done for frozen embryo transfer cycle. And once your lining reaches preferably more than 8 triple line pattern, good blood flow, blastocyst transfer can be planned after administering progesterone for 6 days. So for day 5 embryos in HRT cycle, I also practice giving progesterone for 6 days prior to embryo transfer. Luteal support, all of us know we have suppressed the ovulation here in HRT cycle. So continue progesterone administration until luteoplacental shift. I practice giving it till 8 to 9 weeks of pregnancy. The advantage is it is more convenient and flexible to schedule FET, and a lower cycle cancellation rates are there. So I hope now this is very, very clear what are the various ways to practice frozen embryo transfer cycle. Now, what does literature says regarding different endometrial preparation protocols before frozen embryo transfer cycles and their outcomes? So they say the difference between natural stimulated HRT, that there is no corpus luteum in HRT cycles, and corpus luteum has got a protective effect for prevention of GDM, hypertensive disorders, preterm labors, and even prevents having large size babies. So literature does support a bit about the modified natural cycle over HRT cycle. And another point in this article, if progesterone less than 10 on the day of FET, then in natural cycle and stimulated, because there was a controversy regarding, the last slide said that the luteal support is not needed at all, but there are some studies which say if it is less than 10, even if it is your natural or stimulated cycle, it is better to add little bit of progesterone. Now, let's understand little basics about why estrogen, what does estrogen do, why are we after estrogen for preparing the lining. So if we go into the details and depth, we will understand that estrogen actually is a key player which stimulates the expression of progesterone receptors. So whether this estrogen is coming from that developing follicle in natural cycle or modified natural cycle or stimulated cycle, or you are giving it exogenously, there are roles which are assigned to estrogen apart from just increasing the thickness. So it is crucial for progesterone action as well, and crucial for estrogen receptor. So there is a metabolite of 17 beta estradiol, which is catechol metabolite, which participates in the activation of dormant blastocysts. So the blastocyst which you are going to put, and the estrogen which is being produced in the body, either which is given exogenously or during the stimulated cycle coming from the follicle, this helps in activation of that dormant blastocyst as well. Similarly, progesterone is responsible for appearance of pinopods. So these are, if you look at the electron microscopy features of endometrium, so this is how pinopods will look like. So these are small pinopods microscopically which can be seen on the endometrium, and they are progesterone induced formation of pinopods. And these are basically epithelial cells that lose their polarity and microvilli through down regulation of cell adhesion and develop smooth protrusion along the apical surface. So pinopods remove cell surface glycoprotein mucin 1, and this is how they help in implantation of the blastocyst on the endometrium. Window of implantation, all of us are very well aware. If we do embryo transfer within the window of implantation, then your results are going to be there. So this is a short period in which the endometrium is receptive to embryo implantation. It is restricted time frame in mid-luteal phase where the endometrium acquires a functional and transient ovarian steroid dependent status that allows the blastocyst to be secured and further implantation through mediation of immune cytokines. So window of implantation typically starts 6 to 7 days after ovulation, when the secretory activity of gland is at its maximum, and at this time endometrium is best prepared for implantation of blastocysts. So that is typically day 20-21 of cycle. And we know that it's not only the thickness, but the pattern, the endometrial and subendometrial blood flow, everything is equally important. And endometrium is usually hostile to embryo except during window of implantation. So I'm not going into details of what is thin endometrium. So literature does say that even less than 5 mm, 6 mm should be labeled as thin endometrium, but 7 and more than 7, you can go ahead with embryo transfer. So functionality of endometrium is also equally important. We have a study by our own Dr. Nalini Mahajan where she has studied the endometriums and did the transfer at endometrium as low as 6 mm, and they have found that ERA endometrial receptivity assay was non-receptive in these cases in 23% cases only, and rest all it was receptive, and they got a pregnancy rate of 33.3% at 6 mm endometrium and less. So there is nothing like, we have a fixed definition, but yes, how I practice is when I try by all methods and my endometrium is not going beyond 6.5 after multiple tries, I've tried everything, then only I'll be going for an embryo transfer in that case at such low endometrium. But usually my cutoff, I take it as 7.5 and above. And there are various ways to, evaluate endometrium. Transvaginal scan is the one which is universally used by all of us. And this is how we measure at the thickest part of endometrium, outer to outer layer. And these are the various types or gradings by 2D, type A, B, and C. A is homogeneous hyperechoic endometrium. B is multi-layered with intervening area more echogenic than myometrium. And type C is like this, multi-layered with intervening areas hypoechoic to myometrium. For endometrial grading by ultrasound, there are various ways which are described in literature. And this is one of those which is, most commonly practiced is modified Applebaum scoring. And just for a quick revision, let me tell you that endometrial thickness, then vascularization within zone 3, then comes the myometrial echogenicity, then comes the uterine artery Doppler flow, and diastolic blood flow of uterine artery, and myometrial blood flow. So these are few points which are there considered in modified Applebaum scoring. Usually what we do is when we do our scans, we put in color flow and look at the flows which are going inside. I routinely don't do Dopplers, but color flow I always do whenever I'm taking a decision for embryo transfers. But some patients who have a scanty flow in spite of all efforts, then it is a good idea to put in Doppler and look for end diastolic flows as well. Few people routinely also practice doing the bilateral uterine artery. That's a very good practice, but I usually do, go by the pattern, by thickness, by character, and the subendometrial flows going by Applebaum scoring. And I find this is good enough. Unless, there are very, very scanty flows, then I go on to the Dopplers also, which gives us a good correlation. So as I said, 8 to 14, this is also as per literature, the best endometrium. Less than 7 and more than 16 is not associated with good lining. So this particular part of endometrium topic I'm not touching on. If it is giving you a tough time, if it is thin endometrium, then what to do, because Shalini also has to speak. So this thin endometrium, I think we have already discussed in earlier in the same forum, and we can do it again. So I'm going to skip all these slides, which is, like, but I'll come to a conclusion slide, or a you can say the flow chart, how to go about in cases of thin endometrium. What we usually practice is increase the doses of estrogen if your patient is on HRT cycle. Then as far as adjuvants are concerned, the only adjuvants which I use is ecosprin and sildenafil. I have seen gives good results in some cases, some resistant cases. Then obviously hysteroscopy is very dear to me, because I feel that more than half of the cases get solved after doing hysteroscopy. So remember that cases of tough endometrium, when I say is endometriums which are not coming up in spite of all of your efforts, then in around 16 to 20% of the cases, you will definitely find something inside the uterus when you do put in an endoscope, even if your 3D ultrasound says that uterus is absolutely fine. So I'm very liberal putting in a hysteroscope and checking the cavities. And then GCSF also, my personal experience is it gives good outcomes as far as flows are concerned, because it acts by creating some injuries locally and increases the inflammation. And then of course PRP and subendometrial stem cell and all. And when nothing is working, the last resort is surrogacy. So that's all for my talk, and I have willingly not touched on thin endometrium because that is not today's topic. So thank you so much for your kind patience, and if you want to take the questions or maybe in the end, both is okay for me. Thank you.
Yeah. Thank you so much, Dr. Sunita, for such a wonderful, elaborate, and a crisp talk on such an important topic. I guess we can take questions now as we have the experts with us. Sharda ma'am, would you like to comment?
Her talk had been absolutely wonderful. As far as we are concerned, we prefer the HRT cycle, and this is what I feel. But I think modified natural cycle also can be tried. We're doing HRT cycle only.
Okay, what
Sir?
about Dr. Nisha, Dr. Leena?
Yeah, in our center also mostly we prefer HRT cycle, but what I've noticed that due to lot of hormonal tablets which the patients receive, I find their LFT deranged in many of the cases. So in although it is a borderline derangement is there, but in such cases I do prefer to go for modified natural cycle. And in one of my patients, I found the fluid coming up when she used to receive hormone therapy. So, such few cases which are different, I go for a modified natural cycle.
Yeah, Dr. Preeti?
Thank you, Dr. Sunita, for such a wonderful talk. One thing I wanted to mention, when you said day two, of course, we do the scan and rule out the cyst, but there are many who are, probably nearing menopause or who are having some insufficiency. They will have high EQs. So I would definitely like to send for EQ on the second and third day, because these are the ones in which maybe 10, 11, and then follicle also gives an EQ of 157, and then they will trouble you later on. Progesterone will rise prematurely. So that is one comment I wanted to make. Also, you didn't talk about, maybe you could just mention HRT, how many days? Because literature reports pregnancy even after 26 days of
So literature typically reports that you can give it to up to maximum of 35 days. But I have seen people taking so long, usually the results are not good. So if they are taking so long, because if you typically do your embryo transfer between 18th to 25th day of cycle, your blastocyst transfer, you get the best result. This is my experience. So if they are taking too long, I prefer canceling them and, giving them a break of 1 month and then trying again, or shifting on to stimulated cycle. That is my first take. Those patients who do not respond at all and they're not coming up with any method, then yes, you can prolong your HRT till 35 days. This is what literature says. And I'm very happy that Leena pointed it out that LFT goes, because this is also my observation also. So I used to think it's my patients only are having deranged LFT. So frequently this is seen that on estrogens, because as a routine after embryo transfer we are doing LFTs for all, especially when the patients are on HRT cycle. After a week, this is my routine. I advise that blood sugar fasting and LFT. And so many times we see risen LFTs, and definitely estrogens, HRT cycle, lot of doses going. So, but yes, HRT is my favorite also.
That
And
is
I use stimulated cycles when, HRT is not working for some patients. Then I go back to their follicular monitoring cards. So if in follicular monitoring cards I find a better endometrium, that gives me a clue that this is the patient I have to shift on to stimulated cycle for, going ahead for frozen embryo transfer cycle. Yeah, Dr. Nisha, you were saying something.
so.
Yeah, Dr. Nisha.
I usually have three types of protocols. One is then when we use the suppressed cycles. So suppressed cycles are usually we are using for poor responders. Patients where you have unexpected LH surge or something is expected. So for those patients, we are suppressing, giving leupride depot or something and doing HRT. Then there are patients who are like POF and all where we are going for donor egg cycles. In these cases, I'm using HRT cycles. But rest of all the patients, either it is a modified natural cycle or a natural cycle. In case of PCS and all, I use letrozole. And in case of normo responders, where the patient is having regular menstrual cycle, the most important thing is history taking. If the patient is having absolute regular cycle, she is coming for IVF for say male factor or a mild tubal factor or something, the best outcome would be for her own cycle only. If she has, so we don't do anything. We add tamoxifen only because it is a SERM increasing the blood flow and acting as an oral antagonist. So gives us 1 or 2 days window. So all these patients, I am doing a natural or a modified natural cycle. So three types: modified natural or natural for normal responders or normal patients. Then for PCOS, letrozole, stimulated cycle. For poor responders, it is a suppressed glupride depot cycle. And donor and all cycles where you need a donor egg or something, OD cycle, that is a HRT cycle. Another thing which with fluid thing, which I also used to face this problem. It may be because of high dose progynova, but at the same point of time, it could be because of some other thing like some subclinical endometritis or something. So a course of antibiotic along with the giving, slowly increasing the dose. Means I usually start this. I learned from Dr. Abha ma'am in Gangaram. So what we used to do, we used to give progynova like estrogen for single dose for 1 or 2 days, then BD for 2 to 3 days, then TDS for 5 days, and then increase it to 2. I have never gone more than 10 or 12 milligram in my all practices. So, and if a patient still has problem, we used to give transdermal. So transdermal is a very good, replacement for oral therapy because
Even vaginal can be given.
even vaginal. So
Yeah, so there is a salt called estradiol hemihydrate, which is
yeah,
there.
estradiol hemihydrate is also very good. So, but
Is,
most patients with not responding to oral estrogen therapy, they have a beautiful response with the, as you mentioned, natural cycle.
But
Yeah,
one thing, Dr. Nisha, I have seen is that in PCO girls, in their natural cycles and even in mild stimulated cycles, most of the time. So, what is your cutoff? Do you go for embryo transfer in frozen embryo transfer cycles above 7 or above?
With the letrozole 2.5 milligram BD, if you don't get the response, increase the dose like you normally do in a ovulation induction cycle. 2.5 milligram BD for 5 days, then 2.5 in morning, 5 milligram in evening. And you need to give time to these females to get the follicle recruited and formed.
I'm not asking about the follicle, the endometrial thickness, whether it is 7 mm, which is your cutoff, or whether you prefer 8 mm and more.
I try my best to form the endometrium. If there is no transfer done, I give them the benefit of doubt. I have done transfers even at 5.8 and 6, and have had pregnancies also. So there is
Yeah, but
no
ideal
cutoff
is
there.
8 millimeter.
Huh?
Ideally, we prefer 8
I
millimeter.
also
Yeah,
I
we
also don't
we
go by
prefer.
a lesser cutoff.
Yeah, we prefer, but if it is not possible, Then I have done even at this also and have got pregnancies.
Then you look at the flows and maybe
Yes.
morphology of
Yeah.
the endometrium.
Everything is important.
I think morphology and blood flow is more important than thickness. And sir is here, and sir was the first one from whom I learned that up to 24, 25 days of estrogen also we can give. One of the talks of sir, he said that even after giving 24, 25, if you get a good beautiful lining, you can go ahead with the transfer. But yes, we talk about the maximum days. There is also a minimum days. So I hesitate in doing transfers if the endometrium is is been exposed to less than 10 days of estrogen. I
Yes.
try to give at least 10 to 12 days of estrogen.
Right. So the microscopic level preparation of the endometrium, the changes happening, they need at least 9 to 10 days of estrogen. And then only because sometimes patients come in second visit and they have a beautiful 9 mm lining also. So minimum 9 to 10 days of estrogen. This is what I
Yeah.
know.
I
Yeah.
want
Yeah.
to ask sir one thing. Why do we do this daily LH in this natural protocol, sir? When we do IUI, I think the ovulation time is more crucial. Egg is available only for 24 hours, and we do IUI. We don't monitor any LH. But in this, it is a done thing to monitor LH. Patient is also inconvenienced by daily, pricks. And there is a wider window of implantation, especially if it is a natural cycle. Then why can't we just not do, just monitor ovulation and do the transfer? Is LH
So
mandatory?
Nisha is doing a lot of natural cycle. Do you do LH alternate day in natural cycles?
No, no, no. I don't do LH alternate day. I just try to reach
Not needed.
17 millimeter, and then I prefer to trigger and
Trigger.
start my progesterone.
Modified natural.
Yeah, I also do a lot of, somehow my experience is that these days, I don't know, with giving Progenova, many patients you find that your endometrium just doesn't grow beyond 7 mm. So those are the cases where I have shifted my from HRT to the modified natural or natural. Endometrium grows beautifully, results are beautiful. But yes, first choice is HRT because it is convenient to us. We can tide over the weekends, and monitoring regarding the monitoring of LH. See, what happens is, because when once your follicle is 16 and 17 millimeter, and if you're doing it as a modified natural, so I also prefer giving it doing this LH test on the day of HCG trigger. And then I do call patients next day also,
Yes,
and
yes.
depending on the LH also, because in 50% of the cases the egg ruptures next day itself.
That's
Then
probably
your
the LH surge was already on its way.
yeah. So the LH search does give a good idea. So
Then
I
should we
think there
not
is
add antag?
definitely.
Instead of LH, should we not just add antag to these
And
patients?
tag I do not prefer, because with antagonist somehow it causes suppression, because it is like, because it works as a competitive inhibitor. So it suppresses the E2 so much. So I normally do not prefer giving antag cycles in modified natural. Uh, I prefer giving trigger at maybe 17 or 18. Suppose the patient has come, the follicle is already 20. Then it is becoming more frequent monitoring to
Dr.
catch.
I have done series of this modified natural with LH progesterone, very tedious monitoring. And the
Yes.
interesting thing is there will be some patients where ovulation is documented, LH surge has occurred, progesterone refuses to rise. And
Yeah.
some in which progesterone has risen to even 8 before ovulation has occurred. So the variation is really wide.
No, the
Yeah,
only
because progesterone secretion is pulsatile.
yeah.
So at times we normally do not see such high progesterone level even after the ovulation.
I think the only
Sir, we will like Brigadier Sharma to simplify things, because people who are listening are getting confused and confused and confused. Please, sir.
Yes, sir.
No,
We
no,
will try
I
to.
think discussion has made the things very, very understandable and simple. So basically, we have to prepare the endometrium. Uh, the cheapest way would be that you go for a natural cycle, and also you not have the bad effect of estrogens, like LFT rising. And sometimes, the patients have a breakthrough bleeding also. You give them valid, and after a few days, they come with the bleeding. Doctor, I got some spotting and all. Then you don't know what to do next to that. So the first thing should be that, okay, we are planning for a natural cycle, and especially those who are normal ovulatory, patients. So these are the patients where we would like to do the natural cycle. and monitor the follicle, and as less monitoring as good for the patient. Too much of monitoring puts a lot of stress on the patient. So you call her after 10th day, and you see that the follicle is around 16 millimeter or so by the time, and then you uh, see when it is going to around 18 millimeter. Now, once it is at 18 millimeter, you have two choices. One is that you give HCG injection, and then after 36 hours of that, as if you are doing the ovum pickup, and on the ovum pickup day, you start the progesterone. So you start the progesterone after 36 hours of your HCG injection. So that means you're just mimicking your IVF, cycle only. So that the day of pickup, you start the progesterone. And from that day onwards, depending on whether you are transferring day 3 or day 5 embryo. Now, this is the confusion now, how to calculate the number of days of progesterone. So the day you are thinking that this is the day, is the ovum pickup day, or this is the day the ovulation has taken place, both are same, because ovulation and ovum pickup is the same thing. Here you are doing artificially, there it is happening naturally. So that is a day 0. So from that day you calculate. Let's suppose if you are done, you are expecting, so you're given on Saturday night SCG injection. So on Monday you will start the progesterone for her. And if it is the blastocyst transfer, you transfer it on Saturday. That means on 6th day of your progesterone, you will be transferring the embryos. And if it is the day 3, then you transfer it on, say, on a Thursday. Monday you started the progesterone, and on Thursday, day 3 is there. Because day 0 is the day you pick up the egg or the egg ruptures. Both are similar. So that is the day how you calculate, because there is a confusion always there. Some say day 3, day 5, how many days are progesterone. You calculate the progesterone the day you are given the trigger, and 36 hours after that, you would have done the pickup. Now the nature is causing the rupture, and from that day onwards, you start the progesterone. Now, suppose if you have not given the trigger, and okay, the follicle size is 18 millimeter, and you have done the progesterone is normal, and you find that uh, you don't want to give the trigger because the previous history is there that you give the trigger and the eggs do not rupture in her case. So in that case, you start the progesterone once the endometrium is released. You know that the progesterone is normal and the endometrium is 7 or 8 millimeter, whatever is your planned endometrium, and now you start the progesterone that day onward without giving any SCG injection. And then, depending upon how many days you are given the progesterone, you give the do the transfer, day 3 or day 5. Now, the other thing which happens is that the patient who are on HRT, as I mentioned, sometimes they have a if it is not a natural cycle, the HRT you will be doing for the patients who are for the egg donation, or the patients who are having a poor endometrium in their previous stimulated cycle. You saw that the endometrium was growing poor, so now this time again you can't start the stimulation, even mini stimulation, to get the same poor endometrium. So you will start the HRT for these patients, and now the ones you have the reached the endometrium, the 7 to 8 millimeter, and the blood flow is good. You start the progesterone on that day onwards, and then depending upon if you start with the progesterone on Monday, Thursday you do the day 3 transfer, or Saturday you do the day 5 transfer. And sometimes, as it was mentioned, sometimes the program doesn't work. So because that is well rate, so you next time, instead of giving the stimulation and increasing the cost, you can try the stimulation with the hemihydrate, and you'll find that now the endometrium gets well prepared for it with lesser cost, rather than giving a mini stimulation and then preparing the endometrium along with that. Now there are as far as assessment of endometrium is concerned, antibody nucleus is very good. It is the retroverted uterus, which is a problematic. You find that the blood flow you cannot assess properly in them, and even the endometrium looks more ecogenic, as if the gestation has taken place in these uteruses. So if it is a mobile uterus, do bimanual examination, make it antiverted, and then do the ultrasound. Then you may find that yes, now you can very nicely see the triple line. Earlier you were seeing the homogeneous endometrium in the retroverted uterus, or you do the abdominal ultrasound for them. Sometimes there you'll be able to see yes, this lining is not homogenized. It is progesterone factor not taken. It's a triple line only. And regarding, sometimes we find that the endometrium has grown, the blood flow is not there. Now what to do? Endometrium is 7 millimeter or it's already 6 millimeter, and you find it is in zone 1 only. And you know that endometrium will grow, but the blood flow will not be zone 3. So what add-ons we can do to that in these patients? Either you give a sildenafil vaginally, or use a Hemeract gel, which is a arginine gel. You apply vaginally, and the couple should be advised to have a regular intercourse, and maybe adding sits bath along with that. You will find that the next time when she comes, not only the endometrium has grown, even the blood flow has improved to the level which you want. So these are few things. And recently, I had a patient of a hypogonadism, and this lady, normally hypogonadism, we expect them to form many eggs. Once you start them on HLG, and then they may take more time, all right, but they form, they almost behave like a PCO patients later on. But in this case, we just could get around 7 follicles only. And the endometrium was not good, and there was some fluid in that, so we cancelled that embryo transfer and froze all the embryos for her. We thought we'll prepare the endometrium differently subsequently. Now we tried all the techniques, of the preparation of the endometrium. We started giving her firstly the HRT, and that did not work. And then we thought we'll give a modified or a semi stimulation, and then get only 1 or 2 eggs with the lower dosages. That also did not work. Then finally I had to give her the complete stimulation, like before only, and then only the endometrium formed. And during this time, whatever infection was there which was causing the endometrial fluid, I treated that, and then the endometrium grew nicely. And this time, since she again found 5 follicles, so we could do the fresh transfer in that cycle only. Because so hypogonadism patients are another set of patients which can create some difficulties in your endometrial preparation. So that is one has to as we go along, we learn all these things.
Thank you so much. For the detailed overview, and you've given us a very comprehensive ways to how to make the endometrium and how to measure. That was very nice and crisp, sir. Thank you so much. And with this, we move on to the second talk of this webinar today. I myself would be presenting that, and my